Guys, good?
All right. Okay,
Okay.
I'm
You
nervous.
you want to
Never
do
done this before, Scott.
the no worries. You want to do the thing where we count to three and we clap? Okay.
What?
Okay.
What? Why?
I don't know. Something people
To
do
in
to
to
like,
sync up?
yeah, I don't know. I don't know if it helps or not, but then we're gonna do that. Okay.
Okay.
Ready? One, two,
One,
three,
two,
clap.
Two,
three.
three.
Oh, that was
That
awful.
was
Okay,
terrible.
okay. Let's
Now
try
you
again.
gotta put that. Now you gotta put that inside the recording.
Okay. It'll be
All right.
bloopers. Okay,
That's
let's try it.
permanent.
Let's try it again. Okay, ready? One, two,
Two,
three.
Two,
three.
three.
Dude, Bowei, are you okay,
Okay.
bro?
Bro. Okay, we're not spending the entire time just clapping here.
We're gonna get this right. Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. But thanks for tuning in for the first episode of the Super High Yield Anesthesia second edition podcast. We have a special show for you today. The first one being an interview with my esteemed colleagues, Drs. Bowei Su and Kenneth Nguyen. We're all CA-1s and getting started in our anesthesia journey. With that said, gentlemen, welcome to the show.
Thanks, man.
Yeah, of course. So we'll kind of just start off with some introductions. Let's start with telling us where you're from, a fun fact about yourself, and why did you choose anesthesia? To kind of start us off, I'll just start. So for me, I'm from Garden Grove, California. Fun fact about myself is I like to do archery in my spare time if I do have time in residency. And the reason why I chose anesthesia is because I really enjoyed the procedural aspects of the specialty, and I just found the science behind it very interesting. So it was a good fit for me.
Nice. I still got to do some archery with you, Scott.
Oh yeah, for sure. One day.
That's fun. Yeah.
All right, Bowei, since why don't you
Sure.
share?
So I'm Bowei, from Pleasanton, California, or Canada, depending on how far back we're going. Fun fact about myself is I'm a big outdoor person, so do a lot of climbing, camping, just walking around outside. And I chose anesthesia kind of similarly. I like working with my hands a lot, like doing a lot of procedures and all that. And I was actually originally EM, but anesthesia seemed to be the more concentrated and purified form of it. So that's why I'm here.
Yeah.
All right. Again, my name is Kenny. I am from upstate New York, specifically Rochester, New York, about an hour away from Buffalo. A fun fact about myself is that I have had a multitude of jobs, including being a barber. And I chose anesthesia because I really like dealing with all patient populations, anywhere between kids, OB-GYN patients, adult males, females. And I just thought that anesthesia outside of, other than emergency medicine also allowed me to do that and deal with all these patient populations. And again, working with my hands, as the others have said.
Dude, no wonder you're so good at cutting your hair, Kenny.
Yeah.
It's like for our audience here, Kenny is basically our residency official barber. he cuts
Got
quite
my
a
cut.
yeah,
The
exactly.
Got my
specialty,
cut from him like a week ago.
yeah, I did my fellowship in high fades and undercuts.
Perfect. We're gonna
In
have to
fades.
we're gonna have to do an episode on that eventually. All right, so gentlemen, thank you for sharing that information about yourself. We're going to go ahead and get started here. So the first question we're going to kind of get through is, what was your first solo case and how did you feel going into it?
Bowei.
I really don't. actually can remember what I was gonna look through my case logs, but I totally forgot. Uh, well, we were so as a background, we were kind of paired up for at least a week or two when we first started CA-1 year with another senior, another intern together in the OR. So by the time we had our first solo case, it didn't feel too terrible. It was probably some kind of like lap chole or something like that. But I think I remember feeling nervous, but still kind of confident enough in myself to kind of figure out my own flow and what I wanted to do throughout the case.
For me, honestly, I think my first case was an ENT case, which was more freakier than ever that you had to share the airway with um, another specialty. And as we all know from anesthesia, ENT is very much in our space when we're intubating. So that kind of put on the nerves a little bit. And I think, the month that we had during the 3 months of intern year helped with that nervousness. But I think it really set in when everything was all set up and done, and my attending was like, "Are you good?" and then walked out, or like kind of stayed really peripherally. So that was how I felt my first day, and I don't think it was a sick patient either. I think it was just an outpatient ENT case. So,
Mhm.
those factors kind of helped with all of that. Yeah, that was my first case.
That's where I definitely relate with you when the first time the attending says you're okay and starts leaving. It's like, no, wait, come back, please.
Are you sure? Are you
Yeah,
good?
I know, right? It's like,
Are
you
you
sure you're
good
gonna
with me
leave
being
me?
in here by myself?
That is
Is
so
your
funny.
license going to be okay?
Yeah. For me, mine, I remember it was a lap chole actually. So then, as Bowie said, we were initially supposed to be paired up with like a senior resident or another intern, trying to ease us into the process. I was originally supposed to do like a Nora case and down in IR, but then one of the CRNAs called in sick. So then there was like a room without an anesthesia provider. And then next thing I knew, got a phone call. It's like, hey, you're running this case now. I'm like, oh no, please. So then like I was like, oh, I didn't set up the room or anything. And our APD, Dr. Pass, is like, don't worry, I'll help you set up. And I was like, oh, okay. And we're just going back, we're setting up, bringing the patient back. I didn't know anything about the patient. I was just like looking up the chart while I'm like prepping like syringes and whatnot. I was like, oh, thank God, previously healthy. Okay, cool, sweet. so, then, so then I think, like, when we got started, actually felt comfortable because, like, during our intern year, we did a lot of that stuff. But the problem was we didn't get that much exposure to end the case. So I was like, so
Yeah.
what, how do I do this? Do I just turn off all the SIVO, right when the last stitch is in, or how do I do this? So
Yeah,
that
yeah.
so
I
I
think
remember being
honestly,
there for a
like
while.
they never told us how much of an art like extubation is. Like intubation and putting a patient to sleep is, you know, all square, but I think waking up and especially like the goal of like waking up someone very calmly is like such an art form and there's so many different ways of doing it. I think like the first day you're just like, I just want this person to wake up and it doesn't matter if like they're bucking or like they're going crazy and, I just want them to be able to follow commands. And now I think like we're much more comfortable with all that stuff. But I remember those first days. It's like no one told us how to wake up. I think I remember actually
Yeah.
calling my attending and being like, "Hey, like I think the case is starting to end. Can you come to the room and teach me how to wake this person up?"
Yeah.
Yeah, definitely. Like as a med student and all that, we're usually out of there by the time everything gets settled in after intubation. And I don't know if I remember ever going back for extubation. So I was like, oh my God, I've never actually stuck around long enough to see this part of the
Yeah.
case. I don't know what you're supposed to do now.
It's like something about taking the tube out. I just know that's the end goal.
Yeah, yeah,
Yeah.
100%.
All right, guys. All right, let's move on to the next question. So, any interesting cases you came across these past 2, 3 months, or any scary kind of excrement hitting the fan sort of moments you'd like to share?
Well, I know Kenny probably has a lot. As our classes,
Yeah, to all you
our
audiences,
classes, a black cloud,
I am a very dark cloud, and I've had a quite a
storm,
yeah. I basically played
straight tornado.
anesthesia bingo these last few months. There's two that really are in my mind. The first one, happened so not that same day as my first case, but a different day on an ENT service. We were doing like an extraction of like a growth in the maxillofacial area. And, everything, the case was going okay, very smoothly. A previously healthy patient just had some nosebleeds every once in a while. And ENT was kind of chiseling away at this growth inside the nose. And they decided to use like, I don't know a lot of surgical equipment, but they decided to use like a hammer to kind of help, speed the process along. And they took one swing of the hammer into the nose, and the patient basically like I just stopped hearing like a heartbeat on the monitor, and I instantly just stood up. And I thought initially that like maybe like the EKG lead had fell off because it was near the neck or something like that they swung kind of hard and it just popped off. I checked all the EKG leads and there was nothing. There was like everything was okay. And then that's when I immediately realized that this patient was like in asystole. And like I told the surgeons to stop whatever they were doing, turn around, immediately pushed that I had on hand glyco, and then turned around to start drawing atropine while calling my attending. And I just told my attending that the patient was going in, like basically went bradycardic initially because I saw it. I pushed the glyco, and I don't know if it was the glyco because I doubt it was working that fast. But the patient went from like 0, then went to like 10, 18, like 30, stayed in like the low 40s for a little bit. And I think the glyco started going in. As I was drawing the atropine and getting ready to push it, the patient started going up into the 50s. And
Wow.
I just remember ENT telling me that there are some nerves in like the maxillofacial area where if you do press on it or cause a lot of pain in that area, that the patient can get a vasovagal response. And I guess it was a pretty extreme vasovagal response.
To 0.
To
Wow.
0, basically. Yeah, to
Good,
0.
yeah.
Yeah, so that was probably one no. And then I think the second most interesting case, at least it may have been like, just the patient being sick, but I had a ERCP prone in the GI room, and this was my first month, and it was my first ERCP, and we had just flipped the patient over prone, and the patient began to start bucking against the vent, and then that's when like the patient became very tachycardic and hypotensive, and then the tachycardia started going or the heart rate started to go much more down, and that's when I realized the patient was going into cardiovascular collapse. And by the time I called anesthesia stat to the OR, my assumption was that the patient had bronchospasms, and I started drawing up epinephrine. And by the time all the team was in there and telling me what to do, I think the first thing I noticed was that the end tidal was started to be low, and then the peak pressures went way up. And that's when I started bag masking the patient manually and felt a lot of resistance. And then so on and forth, we paralyzed and reparalyzed and gave epinephrine, and everything like kind of turned around, and we actually could end up continuing the case. But that was another freaking one, basically a bronchospasm leading to cardiovascular collapse.
Wow.
Dude,
Damn.
bronchospasms are so scary. Like I had a few of those myself, and it's like even when you're trying to bag and it doesn't go up like the sats, you're like, oh no.
Yeah,
But
yeah,
yeah,
right.
bronchospasms are scary.
You
Yeah, and
just
then
hear that.
when we gave the epinephrine, the patient started to wake up. I don't know. It was like a giant adrenaline rush for him, and he started to he wasn't awake, but like you could tell he was starting to like do things on his own, move his body and whatnot. But I originally thought that there was some issue with like you know a leak or that like I had like a bend in the pipe or the tubing, but I don't know. Everything was straight otherwise.
You could just hear the decrescendoing tone that we love so much
Yeah,
Do,
right.
on the
do,
pulse
do.
ox. It's just bass
What about
notes.
you, Bowei?
Um, I think mine was pretty similar to yours with the ENT case. Mine's was pretty recently. It was that guy who got basically into an altercation, got beat up, got his face rearranged. So he had like orbital fractures, maxillary fractures, septal hematoma, all the basically every front part of his face broken. So I think it was plastics I did the case with because they were working on both maxilla and orbital floor, right? Usually, if they're doing a Lafort fracture or fixation with the maxilla, you could do nasal, right? But they were also working on the orbital floor, so you couldn't do nasal either. You had some nasal bone fractures. They're like, okay, well, you can't go through the mouth either because they're gonna probably wire the jaw shut afterwards too. So I'm like, okay. So I was talking to other people about it, and they're like, "Oh yeah, I think you gotta do a submental intubation." I was like, "What the hell?" And what we basically did was end up being an oral intubation first, but then immediately afterwards they would kind of dissect from the basically the bottom of the jaw here all the way and dissect up a hole into the bottom of the mouth, and then we had this reinforced tube that we took from the mouth and then reinserted through the new hole to the bottom of the jaw. And we pulled through with a drain, yeah, and then a Penrose drain, and then pulled it out the other side. So now we had this tube coming out the bottom of the jaw, making a curve, and then going down to the trachea. So that was, I've never experienced that before. So that was different.
Wow.
And we didn't end up even wiring the jaw shut. So I guess, I don't know if we didn't really need to do that, but it's cool nonetheless. Um, and during the closing part too, when they were kind of finishing their final sutures, the surgeons had also been kind of retracting upwards, against the eyeball, and that caused like a oculocardiac reflex, so that he just all of a sudden Brady down to like the 30s, I believe, and I was like, oh, caused a little bit of a sphincter clench on my end. But the atropine was able to save him, so didn't go all the way down to zero in my case, thankfully.
Yeah, that's pretty interesting. Like, but was that the one
Yeah,
with Dr. Trong as you're attending? Because I remember him saying something
yeah,
like
yeah.
that.
I did it with him.
Oh, okay,
Yeah,
yeah. Because I was doing a
yeah,
neuro case at the same time. He's like, "Oh man, I have a submental intubation in the other
yeah.
room." I'm like,
Exactly.
"Really?" Got it.
So that was pretty interesting.
Gotcha. Wow. I the case I had prepared is not as interesting as your guys's, but I think it's more of like a comical sense for me. It was just an ortho case. I think it was like an RIF of the ankle or something. This really big dude, like this muscular gentleman. So then I was like titrating all my anesthetics down, and then they're like, "Oh yeah, intern's gonna close." I was like, "Oh crap." so then I was like, okay, so I'm gonna like titrate a little bit slower, a little bit slower. But then this dude, he even at like maybe point 0.8 Mac, like he just started waking up. And as I said, he's a very strong dude. So he just ripped both sides of his restraints. And like
Oh,
not
damn.
not like ripped the Velcro off. No, he literally ripped the restraint. And then I blast the gas. And then I'm just trying to grab his arms. I can slam a stick of probe. And then it's like, sir, excuse me, can you not? It's like I
Stop
eventually
resisting.
stop resisting the probe. So then I eventually got my stick in. I didn't even know how much I pushed. I just did the palming technique where I just slammed whatever I had. And then he finally calmed down and then we went from there. But first time I ever seen anyone rip restraints. That was pretty fascinating.
Yeah. Some people just wake up crazy, man.
Yeah.
And I mean, I always thought like the one thing perspective that I had to change was that like, I went to go stay at I went to go to a wedding and I slept at a hotel and I woke up in the hotel and I was really confused on where I was when I woke up. And that kind of gave me a clue to like how patients kind of feel like when they're waking up and there's like, you know, five people looking down at them and asking them to take a deep breath, or open their
That's
eyes
true.
and follow commands. And it's like, I can't imagine what that's like when you're coming from a deep sleep and you have no idea where you, in quote, don't know where you are,
Yeah,
So,
Yeah.
yeah,
Just some dude
yeah.
just
yeah.
Never actually had that kind of like major surgery to be on the receiving end of it either.
Wait,
So
have any of you guys
totally
actually
get
had surgery and gone under anesthesia?
no.
the
Yeah,
closest thing
neither have
I
I.
had.
I have not. I mean, like, well, hey, wisdom teeth aside, like some nitrous, but like, I feel
Yeah,
like I've never gone into like a deep anesthetic from like, for major
yeah.
surgery.
It was definitely wisdom tooth was the closest one.
Yeah. And most of the time they just inject local. You don't really feel anything.
Yeah, exactly.
Yeah.
All right. So thank you for sharing those cases. Now going to kind of move on to the next question. It's like now that we are about 2 to 3 months into CA-1 year, like how do you feel now compared to when we first started?
Well, for me, I think throughout the intern year, like, we'd go in every Wednesday and help set up cases, get it started. I'd help out and everything, but in my head, I was always like, wow, I don't know how I'm gonna be able to do all of this stuff on my own in however many months it was left. Because, it's a lot of things that you're multitasking. Um, including like the charting, the meds, the airway itself, listening to the surgeons, if they need anything, listening to the vital, looking at their ventilatory mechanisms, all that stuff, all at the same time. And it's like, I don't know how I'm going to be able to manage all that, but I think at this point already, I feel fairly comfortable with at least running through the more bread and butter cases from beginning to end, which is like, I think, pretty huge step from just having done this for like 2-ish months.
Dude, it's like
And
it's like a reprieve when you see
yeah,
like a healthy patient that was like a basic case. You're just like
yeah,
it's like a
exactly.
break from like the craziness that comes into our county hospital, honestly.
Yeah, exactly. I sometimes just crave a nice, lap colon care. Just do your standard induction, get them settled in, and then, you're just hanging out for a bit.
Yeah, yeah.
But yeah, like even that kind of case at the beginning of July, it would have been pretty understandably nerve-wracking for, any new CA-1.
For me, I think how I feel in the beginning, yeah, I think like everyone is scared. I don't think there is a seat, and I could be wrong. There is probably a minority of a very small percentage, in my opinion, of anesthesia residents that go into their CA-1 year like that comfortable, even if, even our program having 3 months of anesthesia in an intern year and the last month being like in June so that we can kind of glide into July. I still think July was still like heavy for all of us. And, there's kind of two things that I took away in these last 2 months outside of what Bowei said about just feeling good about the cases is that one, I've realized that like kind of to touch on Bowei's point, like with everything going on, you kind of appreciate the little bit of silence that you have when you finally get everything set up. And then I realized that like anesthesia is like driving a car. A lot of our times that like we're doing stuff like our like figuratively our hindbrain, our like back brain is kind of just concentrating on listening and hearing what the surgeons say or just kind of paying attention to things that change in the vitals. And you're always getting used to like looking at the blood pressure and the heart rate at like a even a consistent basis. Now I think we even look at the blood pressure and we almost like start looking at it right as it starts to, check the next blood pressure because we're so used to every 3 minutes just looking up. And I say it's like driving because driving is a very dangerous task, just like anesthesia is, because we take a risk every time we get into a car. And at the same time, we do it every day, and it's like a menial in our mind, it's a menial task. But we're always just looking at the mirrors. We're always looking at like other drivers, and we're pressing on the gas, pressing on the brakes. And the reason I think that anesthesia residency can be so tough sometimes is just like we come home every day. We think that everyone thinks that we kind of sit all day and we don't do any physical labor, but our brain is like constantly working all the time, whether we kind of know it or not. And that's the one thing that's kind of changed in my first couple of months. And then the second thing that I wanted to talk about was that like what changed in my attitude towards anesthesia lately is not just like that we're just like helping people get through surgery and get these life-saving procedures, but that these patients who are like really sick, like ESRD, who have chronic pain in their back or their legs, or that they have a trouble time breathing and they have heart disease, all these like ailments that cause them pain day after day after day in the hospital. I've realized that I've kind of looked at it now as I'm giving them just a break, a nice sleep from their like, and I don't want to say it in the such a bad way, but their horrible reality that they're like with these chronic diseases. And that's how I kind of treat it now, that these patients, I'm just giving them a nice break from their daily lives.
Oh, I never actually thought of it that way before, but I think it's like I see where you're coming from. It's very difficult for these patients to live with all these chronic diseases. It's easy for us to kind of say, oh yeah, this is a patient with this, but this is like a person that's actually living through all these like, these illnesses and things that we're trying to manage. So that's really cool. I've never actually thought of it that way before.
Yeah, just giving them a nice break, or vacation. We joke about it that, think about your next vacation as they go to sleep. Where do you want to go to vacation? Think about it. And it's like, that means a lot to these patients, even though we do it every, 2 or 3 or 4 cases a day. Like these patients come in and they just want, and it changed when a patient just told me, I just want to sleep. I just want to sleep. I haven't been able to sleep because I've been always in pain with my leg or my arm or my chest or my head. I've had headaches for multiple days now and I just want to sleep. And that's when I realized I was like, yeah, I'm just helping them just relax for a little bit.
Nice.
Yeah, it kind of helps
you through about it like that.
Yeah, it kind of helps you through residency, when you kind of change that kind of stuff.
I get jealous of them sometimes looking at how much sleep they're getting. I'm like, wow, I wanna be as peaceful as this guy right now.
Dude, the funniest thing is that as residents, we are so tired, but the irony is that we are surrounded by people in bed.
Yeah. Especially us. Everyone is asleep. Except us.
Yeah.
Like I always thought it was so kind of similar to you guys. Like even though it's only been like 2 months or so, like I feel like we made pretty big leaps in how comfortable we are in the OR. So in like June, July, I put in the tube, I tape it, I'm like, what do I do now? So And then
Yeah.
my attendings are like, want to push antibiotics? Like, yeah, that's a good idea. So, like now, like I think as Kenny said, it's like driving a car. Like we just have our flow now, that we can get through these, at least these easier cases, like the bread and butter
Yeah.
cases easily. So yeah, that's, I think it's in such a short time I think we've gotten so much better. But again, there's so much
It's a
for
lot
us
more.
to
Yeah.
learn, to get better at. So
Yeah.
even though we made the strides, that there's always more to learn.
I
Um,
think at the beginning of it, it's not even, well, it is the medicine, obviously, but a large part of it is also just all the random little things, non-medical, like, remembering to put your Temprov in, remembering to spike a bag, remembering to, drop certain meds, remembering to, do this and this and that. And it's just like building your muscle memory, like, remembering to put your car in drive, remembering to signal when you turn that you need to like move from your active frontal lobe processing to like, subconscious almost where you're doing without thinking about it. That helps a lot with the rest of we'll focus more on the medicine part of it.
Definitely agree. All right, so our next question. Do you feel like anesthesia was what you imagined as a med student? Like, is it easy? Is it harder, different? Like, how so?
I think that it is much harder than I thought it was going to be, coming from med school. And it's not an offense against when we were med students or med students now currently interested in anesthesia, but you just have no idea how in depth anesthesia is from like a periphery. If you talk to the layperson, everyone just thinks we put people to sleep. If you talk to the general like medical community, we just deal with pain and in quote putting people to sleep. But there's so many anesthetic considerations that we have for patients, and it's not only the medicine, but positioning, our ergonomics for ourselves, like how we adjust our the IVs to where we want it to be, so be very accessible. Like we're just like MacGyvers of the OR, where we're just like using tape and clips and whatever we have. Even we'll just rest the IVs on like the little Christmas tree or like things like that, or just like trying to make things so that we can see everything and that it's easy transition from one person to the next who's giving us a break, labeling everything, and remembering our narcotics, things like that. Like there is just like so many things that we talked about earlier, just being so aware of so many different things. I think it's just you don't realize it until you're an anesthesia resident and you're by yourself, and this patient's life is solely reliable on you. And
Yeah, definitely the I found out that the real primary instrument for our specialty here is not, it's not your laryngoscope, it's not, the drugs, it's tape. It's our primary instrument. We use it for so much random stuff that, like, if we didn't have tape, I don't think we would be able to do anesthesia.
It's like I
brought to you
think
by Scotch.
Yeah, right.
yeah, that's I think that's something for any med students listening into this. We do throw tape at all of our problems. Like, is our A-line crapping out? We're going to tape it. We're going to tape the hand to make sure it's better. We have
Yeah.
problems with lines. You're going to tape it. The tube is not in. You're going to tape
Tape them
it.
more.
So, tape more. Exactly.
Drapes
So
up, you're gonna secure it with tape.
yeah, we don't have the clips anymore, so it's just taped.
Yeah, right.
But yeah, I agree. I think for me, it is definitely hard, well, harder than I thought, just because as a med student, you go in there and you're just, excited to get the airway, excited to maybe try an IV, and you're like, okay, cool. great day. Got my little procedures and that's it. But you don't see all the other stuff behind the curtains as you would if you were the sole person in there responsible for all those things.
Yeah, it's honestly
Um,
the fast thinking, like making your differential based off of what are you know about the patient, and like just like in general, like looking at the vitals and just being able to tell what's going on from like the
yeah,
information. Of course, like there's a lot of things that these different monitors can tell you, but you're like basically looking at every single one of these factors, the sed line, the ventilator, the vitals, and just making it like three or four differentials on why you're having an issue, like
yeah,
if it's not
yeah,
related to like a monitor issue, and
yeah.
like the EKG leads are off, or like the blood pressure cuff isn't working. It's like if it is working, then why am I having these issues?
Yeah, it's all troubleshooting.
Yeah, and it's so acute is what I was kind of trying to point earlier. Is just like you make such a decision so fast. And as med students, it's easy to, or I wouldn't say easy, but it is relatively more easy when you have like you're on the floor and you can give medications and see the long-term action of these medications over a certain amount of time. But everything that we're doing is like the patient's reacting in 30 seconds, and we have to make a quick reaction in less than like 5 to 10 seconds.
Yeah,
Yeah, definitely
We're
agree.
helping to
Because
stabilize the patient to the point where we can think about what we're doing.
yeah,
yeah. And I think with me, like going from before, where I was saying, like getting all this baseline stuff into muscle memory so you could think more. It made the procedures once we got the whole flow of things, made those more fun, be able to get those, be able to think about the troubleshooting more and less stressful, just knowing what to do with each piece of equipment. But it also made the physiology side a lot harder too, because then you discover all this other physiology, and the more you know, the more you don't know. I mean, it's like that whole the curve, figuring out more of the what you don't know that you don't know into what you know that you don't know.
it just
Yeah.
keeps going and going and going.
It makes you
Just
scared.
keeps getting
It
deeper.
honestly makes you really scared. Being like, oh, like, wow, I actually don't know what I'm like that much. Because you find out that next fact and it leads to like eight different other facts.
Yeah.
Exactly. Yeah.
Sometimes I take comfort in the fact that something that I don't know is something that the general anesthesia community also doesn't know. Like, oh, okay, it's not just me.
Yeah.
It's just no one knows how this stuff works.
But it works, so we just give it.
How
Exactly.
about you, Scott?
Yeah, I definitely think it's a lot harder than what I witnessed as a med student because the ones that I sat on are generally like relatively healthy elective cases. So then like usually things went by really smoothly. So I put in the tube and then I just check out after that. I'm just sitting there. But yeah, like you guys kind of mentioned, like there's so much stuff to, keep in track. And I think the unique part of anesthesia is we're the ones that actually push the meds. Like we put in the lines, we push the meds according to the situation. Because like when we're on the floor, we all we do is we sit behind the epic and then we put it in the order, and then the nurses give it. But like we just
Well, it
bypass all that.
goes to pharmacy. They check the
Oh, that's true.
dosing, make sure it's right. They call us and tell us that we put in a ridiculous dose that no one ever uses, and we're like, "Oh
Oh,
yeah,
it's like yeah,
did you want to do this?" And say, "Yeah, that's what I meant."
yeah,
And
exactly,
then they put
exactly.
it through.
Actually,
Yeah.
July of intern year, I
Yeah,
those calls, pharmacists. If for some reason you're listening, thank you for preventing me from killing my patients.
Or saving a lot of people, saving just us and just like making our lives easier.
Yeah, exactly. All right. So we'll kind of move on to the next question. What did you wish you knew before starting, say, 1 year and or like anesthesia residency in general?
I took the last question first, so you go first, Bowei.
I guess this kind of just popped into my head, but well, I guess this kind of also goes towards the advice too, because it's also things I wish I knew. Is that like with anesthesia itself, I think somebody had told me later on that, oh, you shouldn't be sitting down until like the drapes are up because there should be like a lot of stuff to do before then, which kind of was a good reminder of me to like, be very thorough, make sure, everything that needed to be done was done. And sort of to have like a mental checklist of things that you should be running through for each of your cases. And that's helpful. The checklists are helpful and like a pre-flight checklist to make sure, all the important things are done and you don't miss out even on like minor things, like forgetting to put a temp probe in or forgetting to turn on the bear hugger, forgetting to, like clamp down the IV a little more so you're not bolusing them a liter accidentally post induction, just all that, all those kinds of things. So I guess my what I wish I knew is just to have like that sort of checklist, not just for preparing the room that I didn't know, for med students out there, the MS maids, look that up. But also after the case starts to a second kind of checklist.
Yeah, that's actually a really good point because what I actually started doing is I just had all the stuff I need to do just out on the field from like left to right. It's like I have my intubation stuff, I have my antibiotics, the
Yeah.
Decadron, I have my temp probe there, I have my OG tube. I just have it out. So when I'm looking around, I'm like, oh, I think
Yeah.
I'm supposed to
And I
do
see
something with
it.
this. So so that's
Yeah,
what I do
especially
now.
with like the OG tubes and stuff. Yeah, now I just pull it out and have it on the table, so it's like a visual cue too. I'm like, oh yeah, that's right.
Exactly, exactly.
For me, it was realizing that you couldn't leave the OR. Like, I mean, surgeons can't do it either because they're scrubbed in, but we physically can't leave because, we're managing an airway and like all the vital signs. And like just
Yeah,
not being able to go to the bathroom or like drinking water,
yeah,
eating food. We're basically mandated to our breaks and our lunches. We run, we get 30 minutes for lunch if we're in the middle of a case. And, it takes like 10 minutes to walk down, get your food, order it, and come back up. You eat your food for like 10 minutes, and you got 5 minutes to kind of reprieve and relax, and then walk back to the room within the last 5 minutes. And so, and then, also going to the bathroom, number one or
yeah,
number two, it's like, oh, I guess I just won't eat today because I have to go number two.
yeah,
So those are little things and that I kind of wish I knew going before residency is that we are not allowed the luxury of eating while we put in orders and other such things.
yeah, yeah. We like run on basically our time from CA-1 year onward is runs on OR time at that point. You
Yeah,
don't get your own time anymore, which was a yeah, I agree. That was
big
one of
time.
the unfortunate realizations for me too. Definitely missed, when I was on medicine or any of those wards specialties where I could, put an order and wander down for lunch and take like an hour to, or however long it was, as long as nothing was happening, you could hang out
Yeah, or
down there
even
and
just
eat your
eat
lunch in
lunch while you're
peace.
sitting at the computer.
Yeah, go run to the bathroom whenever you want. So yeah,
That's actually like something I was going to say too. Like, I didn't realize how both mentally and physically taxing it is. Like, again, like we kind of mentioned this before, their perception of us, we're just sitting there. It's like, how could it be tiring? How could it be like mentally exhausting? But we always thinking about what's the next step. How are we going to like manage a patient if things goes downhill? How am I going to emerge? And like Kenny said, like what if I need to use the restroom after I induce? So like,
Yeah, you're
so
stuck, dude.
so you just gotta hold
Dude,
it.
there's nothing worse. I'm telling you, when rushing for a case and realizing that as soon as you intubate and everything, you start to relax, that you realize you have to use the restroom.
Yeah,
You're like, oh man, I should have went before. And then now like you're trying to like mentally juggle like your own bodily functions while mentally juggling another person's bodily functions.
exactly, dude. Like I had this case where I was just like doing the potty dance behind the drapes or something. It got to the point I couldn't hold it in anymore, so I had to call our seniors like, can you send someone in? I can't do this anymore. So
Yeah.
it's like it's something that like as a student we're as you said like we're not bound to a room, so you can go take a break whenever you want, whatever. But now like we our responsibilities to the patient, so we can't just pick up and leave. So yeah, definitely something we wish knew.
The high tip there is just to, anytime you have a break, is to always end your break with going to the bathroom. So you know you start on an empty tank there.
Exactly.
Yeah.
All right. Actually, it's a good segue into our last question. You have any advice for any of the interns out there, the clinical base years, on either the surviving intern year or tips on starting CA-1 year?
Um, I guess for me, I think for going for intern year, I think it was nice to keep in perspective that it's basically the entire year is just a massive farewell tour of the rest of the hospital and the rest of medicine that you won't have to be dealing with after intern year. You know, all the rounding, the notes, the orders, all that stuff. And just to kind of appreciate the fact that you know you won't have to ever do that again unless you want to with crit care or whatever. um you won't ever have to deal with that again. So no matter how tedious or how tired you are on those rotations, just don't forget that that's probably the last time you'll be doing it. I think the other thing for intern year was, I thought, just getting into like what we have been doing, getting into cases every so often, like once a week, to help start it was really, really helpful too. Just getting your feet wet and then being able to get your reps in and being able to do all these random things again for the first time, like, spiking a bag, all those random stuff that you might not have gotten to do before as a medical student, setting up an Alaris pump, all that random stuff. Just being able to do it once to get your muscle memory and will help out a lot. The less first that you have to do in July, the better.
Yeah. I think my like advice to like interns and CA-1s, specifically interns, is if you're a prelim in medicine, try to think about how every single one of the pathologies that you deal with in medicine on the floors may affect your anesthesia. It doesn't have to be every day, it doesn't have to be every week, but every once in a while, think about like, hey, how is this patient's diabetes, or how is this patient's, body habit that's going to affect my anesthesia? And then if you're a surgery resident and you're dealing less with them, like a little bit less medicine, and you're scrubbing into cases, maybe help out in the OR to set up and be like, hey, what can I do to help you out? And how can you think about how the patient's positioning is? Like, you're in the OR more than people who are in prelim medicine. So just watch how the anesthesiologist is like moving about and, adjusting his table for you and whatnot, and have that perspective going into it when you start your CA-1 year, so that you're not, one, thrown off, and two, that you have a consideration for like now everything on the surgical side and anesthesia side and medicine. Yeah. Because at the end of the day, as anesthesiologists, we are the bridge, in my opinion, between surgery and medicine. We take anesthetic considerations of both surgeons, how they're positioned, how their surgery is affecting the physiology, and then we also take consideration of the patient's previous health and past medical history to mix that with surgery. I think we're just concocting our cocktails based off both those things.
Yeah, like I definitely agree with that. Kind of goes into what I would give as advice for the CPAYs is essentially try to learn as much as you can from those rotations, those officers rotations, like all the medicine, all the surgery, because I didn't realize this starting intern year, but all of that is super important when you are doing anesthesia, like all knowing the disease process, like for a patient, like type 2 diabetes, ESRD, all that stuff that we manage in medicine is something we still have to manage in the OR because the diseases don't just disappear magically after we give probe. So, so like being able to manage those diseases helps you optimize the patient better. Think about your anesthetic plan a little bit better when you grow into CA-1 year. So definitely try to learn as much as you can from intern year, even though we all hated those rotations. That's why we did anesthesia. We don't like rounding. We don't like writing notes. But the core content for those rotations is very valuable, I think. All right, guys. Anything else before we kind of wrap it up?
We want to try that 1, 2, 3 clap thing before we end.
Okay, let's do it. Okay, ready? Okay,
all right, Bowei.
Okay, you guys are ready.
Bowei,
okay,
let Bowei count.
Okay, Bowei, you count.
I thought we're all counting at the same time. It's just one person.
You started. You
Okay.
say ready, set, and then you say you.
Ready, set, 1, 2, 3, clap.
Yeah,
got it. All right. So thank you guys so much for your time. I think this was a very engaging conversation that many CA-1s across the country, the world, maybe can relate to and know that you're not alone in the struggle. So in order to wrap up this conversation, if you have a joke, a fun fact, a pun you want to share, please do.
Let's see. I don't really have a joke. A fun fact about anesthesia.
It can be by anything.
I think that for me, a joke / fun fact is that surgeons really only talk to us about bed up and bed down most of the case. Other than that, very little communication sometimes. But that's kind of like something that we have to strive for. Be meeting our counterparts halfway and always talking with each other, building the camaraderie. But less of a joke. But it is funny that most of the time we're really quiet until I hear, "Hey, can you turn the patient lateral, please?" a little bit of tilt.
Yeah, we're professional bed operators. That was a part of the job that I wasn't.
I'm adding that to my resume.
I went to med school to be a bed jockey.
That's our joke for the day.
My high-yield tip would be, or when you see a med student sort of doing the closure for a surgery and it's just, taking a lot longer than you would want to. It's, 7 p.m., you want to go home. High-yield tip would always be to just let them know that you're running out of SIVO and you maybe got like 5 or 10 minutes left before they wake up so that they can kind of, do their last sutures a little faster. You can also imitate the noise of like just gas escaping too, and just to make it more believable.
All right. And I guess I'll end with a joke then. Something that I just saw on the subreddit Dad Jokes. So the joke is 2 slices of bread got married. The ceremony was going great until someone decided to toast the bride and groom.
Hey.
All right. That is it for this episode. Thank you, everyone, for tuning in. And thank you, Drs. Kenneth Nguyen and Bowei Su, for joining me. It's been great. And hopefully we'll have you on sometime in the future.
All right. Thank you, Dr. Thank you, Dr. Nguyen, for hosting. And remember, everyone, all the residents out there, no matter if you're anesthesia or whatever, you're making a difference.
The Dr. Jed Walpole.
Yeah.
Ending.
Jed Walpole sign off.
It's like if you're
and appreciated.
Dr. Walpole, if you're by some weird reason you're listening to this podcast, I would love to do a collaboration episode of you. That's like been my dream ever since I started this. But anyways, Thank you everyone for your time.
Peace.
All right, gentlemen. So the Zoom meeting time is going to end soon. So, so it is a
So
thing.
take a quick break
Yeah.
to hear from our sponsors right now.
Brought to you by Dripavan.
Dipravan and Sugamadex.
That's a plug for us, guys.
I wish, man. I wish that'd be
wish.
phenomenal.